Next on call, coping with arthritis.
And this I've had for a number of years.
And treating the pain.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
Oh, that's good.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard! Blow, blow, blow! Keep pushing.
Just your head.
Pull red handle to open bag.
Hello and welcome to On Call. I'm Tammy Watson. The usual symptoms of arthritis are pain and stiffness in a joint, and there are a number of different kinds of arthritis. You may be most familiar with osteoarthritis, the kind that's usually associated with aging or injury, and we're going to talk about osteoarthritis on our show tonight. But we're also going to address other types of arthritis as well, such as the types of arthritis that are associated with autoimmune problems. So get ready for our Ask Anything About Arthritis show. Joining me live in the studio tonight are Dr. James Engelbrecht and the On-Call medical editor, Dr. Rick Holm. They are ready to answer your questions about osteoarthritis, rheumatoid arthritis, psoriatic arthritis, maybe even ankylosing spondylitis. And if you stay with us, yes, I pronounced it correctly, I think. Stay with us, you will learn about that. The phone number for you to call is 1-888-DOCTOR-ON-CALL. Again, that's 1-888-376-6225. And helping answer the phones tonight are volunteers from the South Dakota State University Pre-Professional Science Club. These are our future doctors and healthcare professionals. Dr. Holm, before you introduce our guest, I wanted to ask you, arthritis kind of seems like one of those diseases like, yep, you're going to have to live with it and you're going to be in pain. Is that a real wrong-headed way to look at this?
Well,
loaded question.
Yeah, I have to, I love to be a guy who has an answer. They come in with this and I go, I know what that is. Look what we're going to do. Problem solved. Everybody's happy. There are, by the way, in certain types of rheumatoid arthritis and certain types of kinds of inflammatory arthritis, some answers now, finally, that are, here's the solution. Patients are remarkably improved, but at the same time, there are also some kinds that are a long struggle. And there are certain types. Osteoarthritis is a very frustrating condition for many people and for the doctor as well. But, maybe we're going to have some good answers today.
We're going to learn
We're going to learn tonight, so we've got just the man for us. I'm very pleased to introduce our guest for this evening, Dr. Jim Engelbrecht from Regional Medical Clinic in Rapid City. Dr. Engelbrecht specializes in rheumatology, has been working with West River patients for over 30 years. Welcome, Jim.
Thanks, Rick.
Glad to have you here.
You bet.
So, tell me, let's start about what a rheumatologist is. A rheumatology internist.
Rheumatology is a subspecialty in the field of internal medicine. So if you think about internal medicine and how it gets divided into cardiology, if it's kidney, it's nephrology, infectious disease, rheumatology is just another one of the internal medicine subspecialties.
Right. So you were chief resident of an internal medicine program.
I did graduated from Iowa, and then I was University of Utah internal medicine program and was chief medical resident and then went on to rheumatology fellowship after that. So you have to be an internist to be a rheumatologist.
Where did you do your rheumatology fellowship?
At Utah. Everything in Salt Lake, University of Utah.
So after your, even while you're doing your chief residency.
I did a little bit of mix and match there, okay? I was doing internal medicine, and I was the chief medical resident, but I was doing a little rheumatology on the side and kind of...
Balanced it all.
Yeah, you know, I did 6 years and 5. That's pretty good.
That's pretty good, yeah. Enough training, though.
Yeah,
and you've been out practicing for 30 years in Rapid City?
Yeah, I went to Rapid in 1980, so I've been there, yeah.
For a while.
Start my 32nd year this summer.
So, well, I mean, you're the man. We're going to be calling for questions of all kinds of arthritis. Stump the Star. This guy is the hero of heroes. We're glad to have him with us. So give us your calls. We'll talk about it more right after this.
Most forms of juvenile arthritis are autoimmune disorders, which mean that the body's immune system mistakenly attacks some of its own healthy cells and tissues.
Arthritis pain is near the top of the list when we talk about the aches and pains related to getting older. A while back, On Call spoke with a woman who has been diagnosed with osteoarthritis pain and with her physical therapist. We're going to bring you that story again tonight so you can hear about how exercise and activity can benefit those living with arthritis pain.
Little steps.
Little steps, and it's okay, you know, just a couple days.
When Helen Peterson talks with her physical therapist about exercise, it's a conversation that's realistic and encouraging.
And you know, it's so simple.
It's so simple.
You know, you can do all these in less than 10 minutes.
Peterson is 86 years old and lives with pain from both osteoarthritis and spinal stenosis, a condition that puts pressure on the spinal cord. Both of these concerns are more commonly found in older individuals.
It's very manageable, although there are days when I think it isn't, when it really, you know, because you ache and you're... And this I've had for a number of years, and now it just flared, but that's what arthritis does, I guess. It will decide to act up in different parts of your body.
Peterson's physical therapist, Chuck McCullough, sometimes uses heat via a paraffin wax treatment to soothe arthritis pain in the hands. But McCullough says that overall, the best way to manage arthritis pain is to stay active.
Actually, you need to move it so you don't lose it. It's very important that patients start an exercise regime to keep their body moving. The opposite would be as if a person just laid in bed rest, they just become stiffer and weaker. Now, obviously, an exercise routine must be custom made to a person's needs. You don't push it to the point of pain. No pain, no gain doesn't count. You work within your tolerance and you keep up on a consistent routine. Over time, it should help you improve your function and strength.
McCullough says that a physical therapist can help individuals overcome obstacles to being active.
Certainly there are certain conditions and certain exercises that may not be appropriate for a person depending on their condition or medical status. But often even simple things, if a person maybe can't walk because of some lower extremity or leg problems or really bad arthritis of their knees, they can even just do some hand exercises or some sitting version of exercises rather than just going for a walk. So I think sometimes we need to understand that there's always a way to find a way to exercise. That's where your physical therapist can come in and help you find what's successful.
Peterson understands McCullough's message. For an older individual like Peterson, surgery to address her back pain is not the best option, and pain medications for her osteoarthritis can be hard to tolerate. So her solution is to keep moving.
You cannot go sit in the rocking chair. You have to keep moving and stay active.
Doctors, I wanted to ask what we should take away from Helen Peterson's story, but maybe first you want to explain the difference between osteoarthritis and some of these other types of arthritis. It's not all the same thing.
No, I think it's very important to clarify that osteoarthritis, that common degenerative arthritis that can occur as we grow older, or it might be a matter of the football injury, destroyed knee, is different than a lot of other things. Jim, how would you describe the difference?
You know, I think if you look at where the disease process or the breakdown starts, with osteoarthritis, it really is a cartilage problem to begin with. Something's gone wrong. Now, you mentioned football injury. Yeah, you beat up a knee and the football injury, recurrent surgery, that damages the cartilage. And then over a period of a decade or 15 or 20 years later, you have some localized degenerative arthritis. So it's a process that starts in the cartilage. It's a degeneration or That's where degenerative arthritis comes, the degeneration of that. And then the dysfunction, the pain, and sometimes inflammation that goes along with that, as opposed to other kinds of arthritis where it's more in the immune system.
So the immune system attacks. Give examples of the other kinds of arthritis.
Okay, well, you contrast osteoarthritis with, say, rheumatoid arthritis. Rheumatoid arthritis, we know there's an immunologic process that goes on where you start to produce antibodies or you start to produce some biologic things that attack the actual lining of the joint.
Why? Do you know why that happens?
We don't know why that happens, okay? We have a lot of ideas. We think there's a trigger of some kind out there, something that triggers this response. There's a little bit of genetic programming because it is heritable. It does tend to run in families a little bit more. So it could be environmental, it could be viral, it could be some kind of a trigger. Get the right immune system and the right genetics all together, and all of a sudden you've got this process that's attacking the lining of the joint. And the lining of the joint is like this little cellophane, very thin membrane that once it's attacked, it gets inflamed and it casts off all kinds of fluid and destructive things, and then that destructive process starts from that. So it's a vastly different pathology between osteoarthritis and rheumatoid or lupus or one of the other autoimmune diseases.
You know, and if you look at osteoarthritis, I mean, you see perhaps a person with a hip that goes bad, that cartilage is thinner, 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 and you've got bone on bone. Explain, you know, is it just because that cartilage doesn't have the strength to...
Yeah, you know, if you get the interesting thing about it is that if you look at the football injury, and I hate to keep picking on football, but they do get injured a lot, and so you know that's you know what you did to the cartilage. You did something, you injured it, it's fractured, something's wrong with that cartilage, and it's never going to be right, and you're going to get deterioration. But there's other forms of osteoarthritis where the cartilage is just sort of starts to deteriorate on its own, and so you get in certain joints, these aren't weight-bearing joints at all, the DIP joints or the distal joints of your fingers get knobs on them, bony knobs,
they
hard
look like
knobs.
the Wicked Witch of the West hand, you know, that kind of a deal.
And
for no reason at all.
For no reason, and that...
We're all staring at our hands now, all the women
well, I mean,
it.
and you know, it's interesting with the hands because I can look at somebody's arthritis, and depending on the distribution of where the pain, swelling, inflammation is in the hands, I can get a pretty good idea of what area I'm in, okay? Degenerative arthritis tends to be in the distal and the middle here, and it's bony, it's hard, it's knobby. Rheumatoid tends to be in the bigger knuckles, a little bit in these, so there's a little crossover here, more in the wrists. But then the base of the thumb, that tends to be degenerative. And then if you get into psoriatic, sometimes it can be just one finger, or it can be a certain pattern in the fingers. So the pattern of where the arthritis is and how much inflammation is really important in terms of trying to figure out what you're dealing with.
Yeah, and now you mentioned, so I'm fine, I've got an idea that rheumatoid arthritis is where our immune system says, hey, I've got an invader, I'm going to go fight it, and oh, oops, you're destroying the wrist and the knuckles of a person instead of fighting an important infection. It's something screwed up on our immune system. And osteoarthritis is this degenerative thing that you see on the distal part of the fingers, and we don't know why it's occurring. And sometimes it's inflammatory, and sometimes it's a response to previous trauma, but we don't really understand that. But then you mentioned a third one, and that was psoriatic. Okay. And that's another story.
Psoriatic, psoriasis, is the skin disease. People know what psoriasis is, and we're not talking about a trivial disease here. Psoriasis is a serious autoimmune skin disease, okay? Now, it can be hugely problematic when it covers large areas of your body, or it can be just a minor spot here or there, but nonetheless, it's a disease process. And if you take people that have psoriasis, there is a predilection for developing arthritis. Okay?
Predilection, that's the first time
that
today
one. We haven't heard that for a while.
So there is a
tendency to go.
There's a tendency that you're going to develop arthritis, and if you start to look at what that arthritis looks like, it's actually there's at least five different kinds of psoriatic arthritis. Okay, there's a kind that affect the spine, certain joints. Sometimes it's just a few joints, a certain pattern of destruction. So,
but it's immune.
But it's an autoimmune process.
And it's different than rheumatoid arthritis.
Different than rheumatoid arthritis.
And we know that it's due to
something with our immune system, and you know, as smart as we think we are, we haven't figured that out yet, but we're getting there. I mean, we're going along, learning more and more about this, but we don't know what.
Okay. Well, before we get to the questions, my big word coming into this, big term, ankylosing spondylitis. Now that's another
That's
type
another,
of arthritis.
great, let's talk about ankylosing spondylitis.
Ankylosing spondylitis. Well, how about, if you can say ankylosing spondylitis, how about HLA-B27 spondyloarthropathy? Okay,
No,
that's what it's more specifically. It's not really ankylosing spondylitis.
Let's call it HLA-B27 arthropathy.
AS. That's what people call it.
Ankylosing spondylitis.
Ankylosing spondylitis. Okay, so ankylosing spondylitis, years and years ago, used to be called rheumatoid arthritis of the spine. Okay, and then as we kind of figured out things in the middle of the 20th century, we figured out that it wasn't really rheumatoid arthritis. It was a specific kind of arthritis that involved the spine, and it can start in the lowermost part of the spine, the sacroiliac joints, where the spine fits into the pelvis. That's sacroiliac joints. Can work its way all the way up to the base of your skull, and it can fuse the entire spine.
It has a very characteristic X-ray on the spine.
It has very characteristic when it gets that advanced, okay? And so ankylosis is the medical term for fusion.
Okay.
Okay? So ankylosing, spon is spine, itis, spondyloitis. So a fusing of an inflamed spine is what ankylosing spondylitis means. And in 1974, there were some studies done that identified a particular type of gene called the HLA-B27 genetic marker. It's not the gene, it's actually an antigen, but it's a marker for a gene. And that, if you have that, 90+% of people with ankylosing spondylitis have this HLA-B27 gene. But 10% of the normal population is not a good screening test because, you know, you can have it and not have ankylosing spondylitis.
Okay.
So 10% of the population has an HLA-B27.
Yeah, if you just went out and took 1,000 people off the street that never had an ache or pain in their life, you'll find 8, 9, 10, 11% of them, depending on the demographics and the population, have HLA-B27 and don't have any arthritis. So it is, you know, those kinds of things make for terrible screening tests. Because what happens if somebody does that test and you're positive but you don't have spondylitis,
you can't get
you got an albatross around your neck the rest of your life.
Well, anything else? I got to dive into questions soon here.
Well, but how do you use that HLA-B27? Let's finish that point. If somebody gets ankylosing spondylitis.
And the reason it's important because ankylosing spondylitis has a specific cascade of different treatments. It's very effective now to prevent that ankylosis from occurring. Yeah. And so it's really important that we make that diagnosis. So if we have somebody that's got an inflammatory back thing, you know, there are characteristics on the X-ray, there's these things, the different blood tests and genetic markers that we can look for. But again, you want to use them when you know what you're looking for. You don't use them as screening tests.
So if a person comes in with low back pain, you don't do that test?
I don't.
If they come in with what that you start to think?
Well, if they come in with symptoms that suggest spondylitis, okay, they're having nocturnal back pain.
Nighttime.
Okay? Degenerative arthritis in your back, degenerative things, wear and tear in your back, disc problems, that kind of stuff, you're really pretty comfortable once you can find a place to lie down, okay?
Yeah.
If you've got ankylosing spondylitis, the place you don't want to be is lying down because the minute you lie down, you start to stiffen up and things, and so people have what's called nocturnal back pain where they got to jump out of bed in the middle of the night, walk around and move. They like to move. People with degenerative disc disease, those kinds of things, they like to be still.
Okay.
So there's a big differentiating thing.
Yeah. That's a walk-home message.
Okay. Well, our first question was one that was emailed in early. What kind of medications can you use for arthritis inflammation when you're allergic to sulfa and have impaired kidney functions?
Well,
so why are those issues?
Well, actually, the non-steroidal anti-inflammatories, we can have this argument. He and I are a little bit opposed. I'm afraid of the non-steroidal anti-inflammatories, the aspirin-like medications. Okay. You know, the big ones are ibuprofen and naproxen, or Motrin and Aleve, and aspirin. But Jim uses them, and Celebrex is a version of this. And Jim uses them a lot more because he needs to with these people who have this. And I have been opposed to using them so much because they all cause trouble with the kidneys. They all cause risk of bleeding in the stomach. And so since I oftentimes will get them to Jim so he can put them on them, and I have to go, okay, but it's that darn Engelbrecht again. But anyway, that's the point. And sulfa moiety is on some of those. Well, you go.
Well, and there again, you say they cause kidney problems. They can cause kidney problems, okay? But if you look at the data, most of the time they don't cause kidney problems, okay? They can cause gastric ulcers. They can cause GI bleeding, but most of the time they don't. They can cause fluid retention, but most of the time they don't. So yes, they have significant side effects, and you know, if it's the difference between moving and not moving, being able to work and not work, I really feel if I can educate the patient to understand what it is that they're taking, what the side effects are, they can use it judiciously. If they're having problems, they can stop it. I can check their blood work from time to time to make sure I'm not affecting the kidneys, and I can tell you 90% of them I'm not affecting their kidneys, okay? So you can put these things into place. And the other thing that I like to do, degenerative arthritis tends to cycle. You have problems for a while and then it kind of settles down. And I like people to be, you know, if they're hurting, take the medication, but if it settles down, back the medication out of there, okay? These medicines don't have to be on there all the time.
Real quick, how do I know if I'm having kidney problems, or how often do I have to come in to get tested?
Well, you know, you need to notice a change in the times that you're getting up at night. You know, that'll tell you that something's happening with your kidneys. It's a real, true, sensitive thing that a person can say.
And the other thing, if you're taking these on a regular basis, one of the things that can give you, that tip you off that you might be having a problem is fluid retention. If you start to, you know, notice that your ankles are thicker at night and you're retaining fluid or whatever, then you should probably have a blood test to make sure that you're not, you know.
But now we've just said, okay, non-steroidals are the only treatment. I mean, implied by our discussion that this is the only treatment for osteoarthritis or osteoarthritis pain. There are other meds.
Well, and it's with her question. She's saying, I've got renal insufficiency, and there was something else.
Allergic to sulfa.
Allergic to sulfa. So that takes certain, if you're a sulfa moiety-containing medicine, if it's got the chemical, particular kind of sulfa in it, with Engelbrecht, for example, does have a sulfa. If you're allergic to that, you can't have it. Just like if you're allergic to sulfa, you can't have certain antibiotics for, you know. So in that situation, it's very difficult because you've got to figure out a way, what could I use that wouldn't be handled by the kidneys, that would give her some pain relief, allow her to do the exercise, things like that. And so you start using a little bit of Tylenol, maybe a little bit of acetaminophen, but low doses, because if you take too much of that, you run into problems, okay? So you got to be very careful. And then you get medicines like, another one of your favorites, I'm sure, is like tramadol, okay? Tramadol, you know, again, careful. It's not like, oh, take 8 a day and, you know, try to feel good. It's take a half of one with a Tylenol.
I prescribe tramadol today.
Okay.
I mean,
right. Well, I know.
What kind of drug is tramadol?
Well, it's a narcotic that's a little milder, and for the longest time I use it because it's not going to hydrocodone. You know, it's going to the next step before hydrocodone. But the problem is, it's on the Beers list, which is, you're a bad doctor if you use these drugs on the Beers list. I mean, that's the implication. And so I just kind of dumped it. On the other hand, there's a time and a place for it, and it's a mild arthritis pain medicine. Answer.
You know,
agree?
I agree, and I think that the key is to talk to people about what they're taking, and this is how we're using it. We're trying to use it as little as possible. Be smart about it. I mean, all those years of using Darvon, which was taken off the market, never had a problem.
I haven't. I didn't either.
Okay? I have people that are just moaning the fact that they can't get their Darvon that they took at night for the last 20, 30 years. Okay?
I agree. And it's another kind of a mild narcotic like tramadol, and it's been given a bad name by a group of experts who, you know, are very knowledgeable but don't practice. Obviously, because they haven't had to try to help people. No, I was not being negative.
I think that gives us some perspective of how complicated dealing with arthritis is.
It's a complicated. Any other drugs that you think? I've been using a lot of.
Again, the non-steroidal anti-inflammatory, that medicine used to be kind of the mainstay, and it's kind of moved out. They're sort of adjunctive things, especially with rheumatoid, because we've got much more powerful medicines for rheumatoid now. Osteoarthritis is still a problem, okay? It's a problem. But rheumatoid, lupus, ankylosing spondylitis, psoriatic arthritis, all these things we've got.
Okay. There's been a move to use a lot more hydrocodone with acetaminophen. And that combination is something that, you know, we don't get quite as much trouble. There's a recent article that said, problems, people falling, lots of confusion. Same story. I mean, any drug that you use, there are significant side effects. And the take home I have is we use them carefully, like Dr. Engelbrecht says, but you need to not use them if you don't need them.
Okay. Right. I'm going to jump in with a question from Huron, and it's back to rheumatoid arthritis. The caller takes methotrexate 1 time a week for 25 years, also takes anti-inflammatory drugs every day. His joints are becoming shot, and he's wondering if there's another drug he should try.
What's his diagnosis?
Rheumatoid arthritis.
Okay. Dr. Engelbrecht.
Well, you know, that's a tough question, but the methotrexate changed the whole face of rheumatology back in the 1980s, and there was a little bit of experimentation with methotrexate, which actually goes back to 1960. Methotrexate is a chemotherapeutic drug
for cancer,
developed for leukemia in kids. Yeah. Okay, and then some of these kids had psoriasis, and gosh, when they were treating their cancer, their psoriasis got better. And gee, some of those that had psoriasis had arthritis, and gosh, their arthritis was getting better. And by the late 70s, they say maybe we should be trying this in rheumatoid arthritis. And I actually was part of one of the very first studies at the University of Utah. We started right before I left there in
really?
In late 79, early 1980. And I went back, we started this study, putting people on methotrexate with rheumatoid arthritis. And I left there in the summer of 1980. I went back in the spring of 1981 and went back to the same clinic where we were doing this, and I was stunned by what I was seeing. These people on methotrexate were unbelievable. I'd never seen anything like this in terms of responding to something.
They've gotten better.
They've gotten so much better. And so that became, methotrexate really became one of the foundation drugs. So, 25 years is a long time, but that's, and you still can have some progression with methotrexate, but it really changes the course of the disease.
What's the cost of methotrexate for a month?
Well, you can take it pills or you can take it in a shot form, but it's a generic, and so it's got a generic copay, or it's fairly inexpensive. I don't know exactly.
$50 a month.
Oh, it's less than that.
Less than $30 a month.
I would think so.
Okay.
I don't know, but then you got to get lab checks, and you got to take some folic acid. When you take it, it's very important. There's a B vitamin called folic acid, and it's gotten a lot of play with pregnancy and one thing or another. But it's very important that you take folic acid when you're on methotrexate for two reasons. Number one, it protects you from toxicity from the drug. And there's been some recent studies to show it actually enhances the effect of the drug. And so it's been a good thing to do all these years.
But the methotrexate can cause lung disease, for example, or other...
Again, the lung thing, so can rheumatoid arthritis. It's not treated, okay?
So you
There's
don't
rheumatoid lung, okay? I mean, you can get rheumatoid
you're making
lung.
this too complicated.
Right? Rheumatoid arthritis is an immunologic disease, so keep in mind, you can have blood vessels get inflamed, you can have lungs get inflamed, you can have all kinds of blood elements that are abnormal. It's all related to rheumatoid disease. It's an immunologic disease.
That involves every cell in your body. Are you interrupting us?
Yes, I'm interrupting you because I like to interrupt. No, we're going to go to a tape, and it actually kind of continues this discussion about drugs, and then I think we might come back to this gentleman's question real quick.
We'll talk more about methotrexate.
We're going to talk about biologics right now.
Yeah.
They're a kind of medication used to treat rheumatoid arthritis and some other serious diseases. Biologic medications are expensive and complicated to produce, so to learn more about them, I spoke with a professor from the South Dakota State University College of Pharmacy. Professor Mike Lemon is a clinical pharmacy specialist at the VA Black Hills Healthcare System at Fort Meade, South Dakota. Lemon acknowledges that the biologic medications used to treat rheumatoid arthritis can be very expensive.
The biologic medications, unfortunately, are not cheap. On average, per year, most of them are going to cost somewhere between $13,000 to probably $30,000 a year. So on a monthly cost for some of these agents, it's probably $1,000 to almost $2,000 a month for some of these agents.
Right now, pharmacists cannot recommend a cheaper generic substitute for these drugs. The costs of development and manufacturing via genetic engineering keep biologics complicated to produce and expensive to buy.
That may change here in the future. Part of the 2010 Healthcare Reform Act included a clause that is trying to establish a way that they can make a biosimilar medication and kind of go through an abbreviated pathway. So in the future, we may see some generic biologic medications, depending on how the healthcare law continues and what parts of that are upheld.
While scientists, manufacturers, and regulators work to improve the affordability of biologic medications, Lemon says that pharmacists know that the value of a drug cannot be measured solely in dollars and cents.
In many rheumatoid arthritis patients, could be young patients, and what you're trying to do is either slow down or stop the progression of this very disabling disease. So many patients with this eventually become so fully disabled they are unable to work and things. So you look at the cost of a medication, again, $13,000 to potentially $30,000 a year, but then you consider the future. Are we slowing down or delaying or maybe even preventing the process of having to replace various joints in the body, which is very expensive surgery? Are we improving their quality of life? Can they continue to work? Things like that.
Regardless of cost, Lemon says biologic medications are not the first line of defense against RA. Traditional drug treatments are a more affordable and a better starting point for treatment. In many patients, though, these older types of RA medications can lose their effectiveness over time.
The biologics patients do lose response to them as well, and that's why we actually have 9 biologics now that do target the various aspects.
Rheumatoid arthritis is an inflammatory disease of the immune system that targets first the synovium, or lining of the joint, resulting in loss of function of the joint.
Thank you for joining us tonight. Our show is all about arthritis, and you can ask anything about our topic. Here in the studio, ready to answer your questions, are Dr. James Engelbrecht and the on-call medical editor, Dr. Rick Holm. You can call in right now with your questions. Our phone number is 1-888-DOCTOR-ON-CALL. Again, that's 1-888-376-6225. Doctors, I want to go back briefly to the segment we just saw about biologics, and one of the things that was pointed out to me is that a patient taking numerous drugs to treat rheumatoid arthritis can only take one biologic at a time, because these drugs are really potent, and you could really get into some problems.
Let's talk about what a biologic is, Jim.
Well, I think that if we pick up on the question that we left off with on methotrexate, methotrexate clearly was a life-changing drug for a lot of people with rheumatoid arthritis.
And that's
but it's not a biologic, okay? It's a chemical that does something. A biologic, and it gets after cells in a certain way because it's chemical. A biologic is a drug that's a little bit more complicated in terms of the molecular biology, and it actually messes with some of the mechanisms that cells communicate and they signal each other with, and that's what it's doing, and that's where the biologic comes from. There's these communication lines between all these different cells in our body, and they're called cytokines, and this biologic medicine interrupts those lines of communication, and so they can't function, and that's how it interrupts the immune process. So yes, they're very potent drugs, and if you have somebody that has rheumatoid arthritis and it's progressing despite the methotrexate, that's where the biologic drugs come in, because the biologics can then, in a lot of cases, stop that progression. You don't get more destructive changes.
Now, what kind of, number one, how do you make a biologic? I mean, what is it in cultures and tissue and with what's the way they make them? And number two, there's several different groups of biologics.
Right. It's largely based on recombinant DNA technology, and what that means is that they're using DNA maps, DNA plans, to generate a particular kind of a molecule that does something, okay? Now, those molecules could be
made by like E. coli bacteria.
Made by E. coli. It's very complicated, not in E. coli, but there's a variety of different biologic models that they use to make these things, but it's very complicated. It takes a lot of, an enormous amount of science to get to that point, and the entire process has to be sterile. One of the big costs of generating these biologic drugs is you cannot have contamination. These are drugs that you're actually injecting at people's veins. They cannot be, I can take methotrexate and make a whole pile of it, irradiate it, and kill all the bacteria in it, and bend it in a solution, and boom, give it to you, and it's no big deal. This is a different thing with the biologics.
They're protein. They're actual proteins.
They're actual proteins, and some of them are actual antibodies, and so there are antibodies that go in, and you've got this thing floating around in the antibody. It's called a monoclonal antibody, and it grabs this and takes it out of circulation, and that shuts off that process somewhere along the line. That immunologic process is also part of your defense, so that if you get a bacteria or something like that, you can defend yourself. So we're messing with that immune system, and that bacteria comes along, so the chances are you're going to have a worse infection.
I'm more vulnerable to catching...
Your immune system is suppressed, therefore you're more vulnerable to infection.
So no, they're all monoclonal antibodies?
They're not all some of them are what are called fusion proteins, which they are a mimic of the receptor. Very interesting, where they've looked at a cell and said, this is where this plugs in this cell. If we design something that looks like this, and we'll just make it not hooked onto the cell, we'll just let it float around, it'll grab all these things and nothing will happen. Okay, and that's called a fusion protein. It's a receptor blocker fusion protein. Then you have other ones of these antibodies. They're just antibodies, and they just go grab it. They're called monoclonal. So if the generic name ends in MAB, infliximab is the name for Remicade, for example. MAB means monoclonal antibody. Okay, so you know.
Inflicts a monoclonal antibody.
Okay, the words are getting big. We're going to dive into the questions, unless you got to finish up.
No, I think that was fabulous. I mean, and so it glommed onto the receptors.
And it shuts off this biologic process, and therefore the disease cools down. And it's an extension of what we're doing. And just to complete the story, part of the reason that you leave somebody on a drug like methotrexate when you put them on a biologic is that not only does it help you with the arthritis, but your body recognizes this funny thing you're sticking in there as being foreign. And it wants to develop antibodies and get rid of that thing that you're putting in there.
But the methotrexate will
The methotrexate helps you.
Oh,
do
wow.
Okay.
That's interesting.
So, but the final word on the biologics was mentioned by our professor, and that is, and you pointed out that it's very hard to do this. It's very complex. It has to be sterile. You can't just zap it with radiation because you destroy the biologic. Right. It's not going to ever be a cheap generic.
No. It's going to be very difficult to reproduce generically because they're so complicated a molecule. You know, they're going to make it. They're going to try, but my prediction is you're not going to see the drop in, like with the statin drugs, or once they're generic they go from dollars to dimes. Okay, yeah. I mean that's not going to happen with.
No, and these aren't dollars. These are big dollars.
These are thousands of dollars.
Thousands of dollars a month.
Right.
Okay, we got a stack of questions. We got to dive in.
Okay.
I think this first one, unfortunately, you can answer quickly. A female caller, age 48, has problems with her knee. Am I too young to have arthritis?
No.
Even if
the answer is no. And how soon do knees need to be replaced? When do you see the orthopedic surgeon?
48 is pretty young, although having said that, I mean, I've had people in their 30s have knee replacement with very destructive rheumatoid disease where we just had no option. And you have to, but, you know, these knees are you know, store-bought, okay? I mean, they've got a shelf life. They've got a half-life. They're going to last a certain, you know, if you go to the orthopedic surgeon, I'll put this knee in, but I can't, you know, after 10 years, all bets are off. Well, I've seen people go 25 years, and I've seen people go 10 years with them. It's all different. 48's pretty young, okay, and there's a lot of things you can do. If it's an osteoarthritis thing with one knee, there's things that you can do with injections, there's medications, there's exercise, the right kind of physical therapy, lots of stuff that you can do.
Talk about injections. I've injected a lot of older people with knees because I believe that we under-inject. I think injections of knees, for example, can give a great deal of relief. It's inexpensive, it's quick, and it works. What are you thinking about injections? Back injections, knee injections, neck injections?
Well, those are all different, okay? But let's talk about knees. A knee that has degenerative arthritis begins to get inflamed, becomes swollen and painful. And if you put a needle in there and you take that fluid off and you put a little bit of cortisone inside there, it can settle down that inflammation. And that knee might be great for years. It might be months, it might be years, but it might settle it down, and that buys you a whole bunch of time. If that doesn't work and it's just degenerative arthritis, there are some substances now which are called viscosupplementation, which is some of them were originally derived from chicken combs and then modified, and you can inject those into the knee. People know what I'm talking about. I don't like to mention products because there's 7 or 8 of them. Okay, and you know they work okay, but the problem is some of them that are from like feathers and chicken. You know, from chicken products. If you're allergic to feathers or something, you could have a reaction to them. Okay, so you got to be very careful that you're not sticking something that somebody's going to react to. But there's a role for that. But I think that the best thing to do is to handle the inflammation when it flares up, keep the knee strong, lose weight. I mean, a lot of stuff you're doing when you're 48 or 58 or whatever with a bad knee is saying, you know, when I'm 68, I'm going to have a knee replacement. So how can I stack the deck in my favor? I'm going to stay strong. I'm going to do my exercises. I'm going to keep my weight down. I'm not going to go in with all this all these high risk things. And you will not only delay having to have the knee surgery, but you will have an improved outcome when you do have it.
I love that story of the patient with bone-on-bone knees, and they took 100 of them, half of them they exercised, and the other half they kept do whatever you want. And the couch potato, it was a trend. And the difference after a year was that the people who had the exercise felt better, did better. They actually thought that there was some improvement in the cartilage. The best way to do it is to keep going. Now, that's not an inflammatory rheumatoid type of a picture. That's an osteoarthritis. Any comments to that? Well, I've said it a million times.
No, and the good news is that let's say after a year you don't respond and you have to have surgery, you got yourself in great shape. You're a great surgical candidate. You got muscle there, okay? Yeah. You take somebody with a bad knee that's been limping around for years and they got no muscle, and you replace the knee, now you got to rehabilitate this new knee plus all the muscle. It's a
disaster, potential disaster.
Question from Yankton. A gentleman wants to know about Celebrex. How long can it be used? Is it effective, and how does it work?
What do you think, Jim?
Anti-inflammatory medicine.
Any better as far as effect
Nope.
than Aleve or Motrin?
Nope. But there again, you got to compare doses to doses. Okay, is it more effective than is one Celebrex twice a day more effective than one Aleve twice a day? Probably, because it's a higher dose. It's a different, you're giving it a different strength of the medicine.
Less toxic? Celebrex less toxic?
Well, here's what we know: less gastrointestinal toxicity. Okay, so if you have a predisposition to having
heartburn,
acid reflux, ulcers, acid problems, and you have to use an anti-inflammatory, Celebrex would probably be a little safer than the naproxen, which is generic Aleve.
What's the cost of Celebrex?
Expensive. Okay, it's not. It's still hundreds, 150 a month, I suppose, to take.
Okay. Question from Highmore, a female caller. She's been told she has very arthritic knees, and this is a $1 million question. Will knee replacement help arthritis? Questions. Will she be glad she did it? Cartilage in knee is gone, has some pain, but not all the time.
You need Carnac.
Yeah.
Okay, you need.
I believe
when is it a good idea to have surgery?
I think the way I put it is when the person is no longer, and despite efforts of exercise and physical therapy, they are no longer able to enjoy the things that they need to enjoy in life. Then I move in that direction. But it's a very individual deal. Okay. So it's a personal thing. Got to have a relationship with your doctor. And you need to have a relationship.
Go to a good orthopedic surgeon. If you don't like the first one, find one you like. I mean, that's what I tell. I tell people that I will send them to somebody that I go to myself, but that doesn't mean you're going to like them. That just means I like them. Okay, and so you got to have a good relationship with the surgeon. Stack the deck in your favor. See a physical therapist. Do the right kind of therapy. Get that knee ready to be replaced.
Get the muscle strong.
You've tried everything. Get the muscle strong. Get the leg strong, and I think you'll have a very good outcome.
Okay. This question from Sioux Falls switches gears pretty much. Female caller, she has an 11-year-old niece with rheumatoid arthritis. What kind of research is being done on children with arthritis?
JRA, what?
Tons, okay. And, the biologics, several of them are now approved for use, and it was traditionally, when you and I were in school, they called it JRA, juvenile rheumatoid arthritis. It's now called JIA, juvenile idiopathic arthritis. Okay, so now
it's different than rheumatoid, is what they're saying. It's not rheumatoid arthritis.
Here's the quick the quick lecture on juvenile arthritis. 5 different kinds. Okay, there's adult rheumatoid in a kid, bad deal. Okay, seropositive rheumatoid adult nodular disease in a kid, bad. You've got polyarticular inflammation in a kid, but it's seronegative, no nodules, and it's different than the adult. Not quite so bad. There's one that used to be called Still's disease, which is a systemic onset. It's like a flu. They get some they can get an enlarged spleen. They can get inflammation around their heart. They can get fevers. They can get a rash. Still's disease, pretty good prognosis. Can usually get on top of that one, get that under control. There's juvenile ankylosing spondylitis, okay, that you can get. So kids, and especially boys, have more ankylosing spondylitis, and so they can present with an arthritis as 11, 12, 13, an adolescent. And then when they're 30 and 40 years old, they have ankylosing spondylitis. And then there's another form called POSI, which means small, POSI number, small, POSI articular, few joints, arthritis. And that's like 2 or 3 kids. And I see a lot of young girls with that, little 4, 5, 6-year-old girls that have this POSI articular. And sometimes, and they have a pretty good prognosis. Over the years, they do pretty well if you just get the inflammation under control. But all of these, and especially the ones that have the rheumatoid kind, the adult rheumatoid in a kid, the biologics are very important.
And that point we just learned was how good it is to have a rheumatologist. That's why you are here. We need to keep our rheumatologists. People aren't going into that field much anymore. We need them. And thank you for summarizing that beautiful story of rheumatoid arthritis-like disease in kids. I mean, how important.
Before the show, you gentlemen talked about how things have changed in the time period since you guys have been practicing. There used to be gold injections. Talk about that real quick.
And huge doses of aspirin. That was the major thing that I had for people who had bad arthritis.
You don't do that anymore?
And we didn't have, we hardly had rheumatologists, and now we're done with gold. I mean, do you do any?
Yeah, I mean, except in rare circumstances. I think I have one person that still takes oral gold because it works. And gold went through the injectable form and then the oral form. But, you know, we were talking earlier, when I was a fellow, when I was doing my specialty training in rheumatology, I had to do the gold clinic. That was part of the responsibility. And you gave people gold shots, and you had to check their blood, give them the gold shots. So it was basically giving gold and teaching people how to take 16 aspirin a day. That's how you treat it.
16 aspirin a day. Spread it out. Take it one time, depending upon, you know, with food, the whole 9 yards.
And then with the gold, a third of them, it made them so sick you had to stop it, and a third of them it might help a little bit, and the other third, nothing happened, and so you took them off it anyway. And so
yeah.
you know, and so if you think about that, 31 years ago, okay, and what we can do right now, I mean, I've been blessed in my professional career to see the changes that I've seen. Rheumatoid arthritis going from a disabling, destructive disease.
Kill you in 7
control.
years. That's it. It would kill you in 7 years.
Lupus,
yeah.
Okay.
Yeah.
We were talking about this earlier today with the group. When I was a fellow, the 5-year survival rate for lupus was 20%. Right now, the 5-year survival rate is 96+%. It's almost a normal population. Okay. Yeah. I mean, a complete turnaround. Osteoporosis. Okay. What did we do? Put them in bed with a compression fracture. Yeah. Give them codeine. Till they couldn't, the bowels were so stopped up they couldn't do anything. Give them calcium tablets and let them lay around for 3 months and send them home. Now look what we have. Yeah. Okay, I mean, look what we've been able to do with this.
That's a kind of uplifting thing to think about.
There's been improvements.
That's good to know.
It's nice to say that. Now, I like it.
Here's a question. Gentleman has degenerative arthritis and osteoarthritis. Are there certain foods that that would either help the condition or make the condition worse? Or?
Yeah, let's talk about could rheumatoid osteoarthritis, degenerative joint disease, could that be due to a deficiency in a vitamin? Could it be vitamin D? One word on vitamin D. And what about chondroitin sulfate or all these other herbal things that people are taking for arthritis, including copper bracelets and magnets?
So how many hours is the show?
You've got 2 minutes.
Titanium necklaces, I've seen that too.
Okay. Copper bracelets studied 30 years ago, 0. Okay, no effect. Sham, you take that off it's all here. Okay, if you think that makes you better. Glucosamine is a much more interesting story. Glucosamine chondroitin. 1969 is when that was purported to be effective. Okay, so it's been around for 40 years almost, 40 plus years. Yeah. So, and the data is very on again, off again. And if you look at the data on glucosamine, it seems to be a subset of responders with degenerative arthritis. It seems that they're better. So milder disease, earlier use, and an appropriate level of use. So you can't just take an occasional. You've got to be on a regimen, a couple thousand a day. My personal belief, anecdotal, not science, my personal belief is that there's a group of responders. So if I see somebody with early osteoarthritis, not rheumatoid, early osteoarthritis, I will suggest that they try some glucosamine, and I'll lay it out what it is, and I'll say try it for 60 to 90 days. At the end of that time, if it hasn't worked, you're a non-responder. Forget about it. Don't waste another nickel.
How about the chondroitin sulfate?
The chondroitin is, that doesn't hurt you, but that's even less than glucosamine. So I tell people, get the glucosamine unless you can't, if you can find it without the chondroitin, that's fine. If it's got the chondroitin, that's fine. Doesn't hurt you.
Okay.
And then there's a bunch of other stuff.
All the other herbal things.
Herbal things.
Vitamin D.
Here's vitamin D, probably not a role in osteoarthritis that we can identify at this point. Vitamin D very important for a lot of reasons, but not, not for osteoarthritis. The one thing you can do in your diet, and get to the question, that I think is eating foods that are rich in omega-3, fish oils, those kinds of things help fight inflammation. Okay, and so. The omega, you can buy the fish oil supplements over the counter. You can eat more
ground flaxseed,
ground flaxseed, anything that's got those kind of
eicosapentaenoic acid, that anti-inflammatory oil. There it is.
Okay.
Ground flaxseed, 2 tablespoons a day, and it makes your bowels work, and it makes your coat shiny. You've heard that?
That's a win-win-win situation right there.
How can you beat it?
Ground flaxseed.
Yeah.
Okay.
Happy bowels, shiny coat.
Well, we've got to wrap up now on Happy Bowels, shiny coat. Take it away. Give us a minute's worth of wisdom, or
we're down to 1 minute.
45 seconds or something like that.
Number one, 2 things. Number one, there's been a huge evolution in the treatment of arthritis and our understanding and the type of drugs, and it's very important. And the second thing is that There are people out there, pediatric rheumatologists, that can work with your primary care doctor. It's a really good partnership. I've done it for years and years, where the primary care people are really doing the bulk of the work, but we help kind of modify things. We've done it from afar for many years, and I think getting that help and having that team on your side is really important.
Great. Thanks so much, and of course, exercise if you can. We appreciate you, Jim. Thanks for being
Doctors,
here.
thanks so much. If we didn't get to your question, we'll try and get it posted on our website. Now, stay tuned. We will be right back with the homespun perspective and then what's new in medical science.
Looking for reliable healthcare information online? You can start with the resources link at the On-Call website. From there, you can access a variety of accurate and dependable information sources, including the South Dakota State Department of Health and Medline Plus.
Many people deal with a chronic pain of degenerative arthritis, and every day people walk or sometimes wheel into my office asking for relief. Whether it's hip, knee, or shoulder arthritis resulting from an injury that happened years ago, or back and neck arthritis coming from an inherited condition or the aging process, these folks suffer. They have pain during movement, or when they're still and trying to sleep, or too often continuous. Unfortunately, arthritis prevents movement, which only confounds the problem. Of course, we have medical weaponry to fight against such an enemy. I could prescribe exercise, stretching, hands-on physical therapy, topical ointments, pain medicines, muscle relaxant pills, anti-inflammatory solutions, injections, and finally call for a surgeon to repair or replace bad joints. My preference of these is to do whatever it takes to keep people moving and strengthening. Unfortunately, although these options can be very helpful, too often they are inadequate and some people still hurt. Well, in response to continued pain and dysfunction, individuals will sometimes turn to complementary and alternative therapies such as massage, spinal manipulation, progressive relaxation, acupuncture, yoga, tai chi. Also, there are herbal remedies such as glucosamine and chondroitin, gamma-linoleic acid, and many more. I should say here that there is a growing body of evidence, scientific evidence, to support some of these options when used appropriately. In spite of all these standard or legitimate complementary therapies, however, there are those who still hurt and can fall prey to scam artists trying to profit from someone's misfortune and desperation. I would warn people about advertisements that promise too much. Yet it's difficult for me to attack such claims, since our standard therapies for arthritis can also be expensive and inadequate. When all is said and done, people will still hurt. It is simply the human condition, and most often the consequence of staying alive a long time. But I believe the best plan to deal with chronic pain of degenerative arthritis should be to do whatever you can to keep moving. We'll be right back.
Next week, we're going to bring you a show about diabetes. This is a very important topic for South Dakota. Diabetes can lead to amputations, vision loss, kidney failure. It's a serious disease. Thousands of South Dakotans have diabetes and prediabetes, and some people are not even aware that their health is being threatened by this illness. So please make sure to join us next week for a show that I guarantee will have you rethinking what your personal risk of developing diabetes is, and whether or not you need to start making some lifestyle changes to protect your health. Remember, On Call is rebroadcast on SDPB Digital Channel 2, Mondays at 11 a.m. Central and Wednesdays at 4 p.m. Central. Now, once more, I'd like to thank our guest, Dr. James Engelbrecht, and our medical editor, Dr. Rick Holm. Thanks to our phone volunteers, and thanks to you for watching and calling in. Again, if we didn't get to your question on the show tonight, we're going to try and get it posted on our website in an hour or two. We'll see if we're up to the task. Again, thanks for watching. Have a great evening.
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
To learn more about life and health, you can order your copy of The Picture of Health, a beautiful book containing insightful essays and evocative images by on-call medical editor Dr. Rick Holm and Dr. Judith Peterson. This book, containing healthcare advice, stories of medical history, and meditations on healing, can now be yours for $17 at the South Dakota Ag Heritage Museum. Call 1-877-227-0015 to order. This offer is made by Ag Biocommunications at South Dakota State University.